Professor Oliver Comey. I'm going to discuss the main findings in the respiratory system. The respiratory system is an important system in the examination of the child, and one that often fails students unnecessarily. The main symptoms which are referable to the respiratory system are cough of various types, fever, fast breathing, periods of apnea and irregular breathing, and then noisy breathing. Bronchi are in expiration and stridor in inspiration. There are also abnormal breathing patterns, as may be seen in the fast, deep breathing accompanied by the smell of acetone in acidotic patients. Children who have diarrhea, diabetic ketoacidosis, and who have this pattern of fast, deep breathing. Now we shall proceed to the examination of a child with respiratory disease. The main things we'll be looking for on inspiration will be clubbing, pallor, cyanosis, and then a comment on the air exchange, then the respiratory rate, and we'll next look at the palpation of the chest for special things, and then which are auscultate using the stethoscope after percussing the chest. We can now go to the observation or inspection of the child with respiratory disease. The first point in examining a child with respiratory disease is to count his respiratory rate. This is normally counted over 1 minute, and then the figure given, or in children who are less than 2 months of age, is counted twice over 1 minute and then a minute, and an average taken of the two findings. This is because in this young age group, the respiratory rate tends to vary with time. The respiratory rate is important in helping to diagnose pneumonia. In children who are 2 months or below, the rate should not be higher than 60 per minute. In children aged between 2 months and 1 year, the rate should not be higher than 50 cycles per minute. And in all children between the ages of 1 year and 5 years, the rate should not be higher than 40 per minute. It is held by the IMCI writers that the respiratory rate is a very good index of a possible chest infection for the child. And when the rates exceed the figure, the cutoff figures given, one could safely say that the child has a pneumonia and qualifies for antibiotic treatment. Next, after the rate, will be to look at the child's conjunctiva, then and the tongue, the tongue and the nail beds for duskiness or cyanosis, central cyanosis. Children with severe respiratory illness or a cardiac cyanotic heart disease tend to have central cyanosis. We next look at clubbing. If we were to put the two thumbs opposed against each other, the edges of the tongue do not come together. This, when compared to that of the demonstrator who is not clubbed, one can see that there's a diamond-shaped space between the two nails, and then the two nails come together at the top. We shall go back to the child. In this child again, you can see that the diamond-shaped space is missing. The diamond-shaped space in between the nails is missing, and the top edges are apart. Clubbing is an important sign in children with respiratory disease. It denotes a chronic infection, particularly in conditions like bronchiectasis or lung abscess. The clubbing also occurs in children with retrovirus infection, particularly involving the lungs, and infection with pneumocystis carinii and others. In children with tuberculosis, which is also secondarily infected with other bacteria, you could also have clubbing. Clubbing is not a sign restricted to only the respiratory system. We also have clubbing as a result of liver disease or cyanotic heart disease, or sometimes diseases of the intestinal system. The next thing to look for in a child is, we mentioned cyanosis, we mentioned clubbing, and we've discussed the respiratory rate. Children come to us with another sign of respiratory illness, coughing. Children who have simple pneumonia have regular cough. The children who may have whooping cough or pertussis tend to have a repetitive cough. Cough which continues for a while and is at the end followed by an inspiratory sound or vomiting. Because of the successful implementation of the EPI program, the whooping cough is not as frequent as it used to be. So most students of today may not see a case of whooping cough in their clinical practice. After looking for cyanosis, clubbing, and noting the respiratory rate, we get to what we call palpation of the patient, or touch the patient. The first thing we do is to determine the position of the trachea, which tends to be centrally placed above the supraclavicular notch. The trachea could be displaced to the left or to the right based on events taking place in the chest. We next percuss the chest for areas of dullness. We percuss over the clavicles, both clavicles, noting the sound, whether it is resonant or dull. We next percuss down, left and right, and then in the back. Noting, as I said earlier, for resonance or dullness percussion. Dullness to percussion is normally present when there is consolidation of the lung or a pneumonic process is going on. Where there is fluid in the lungs, however, the percussion is stony dull. Not dull only, but stony dull. So dullness is for infections and stony dullness for the presence of fluid in the chest. The next thing we look for sometimes too is hyperresonance, where there is introduction of air into one lung, what we call pneumothorax. The percussion will not be resonant, but will be hyper-resonant, not exaggerated. The next piece of examination we do is using the stethoscope to listen to the chest. We call it auscultation. In auscultation, the stethoscope is applied to the anterior, posterior, and lateral aspects of the chest. And on each occasion, the child is asked to take in the deep breath. What we aim at finding out is the amount of air entry that occurs, which could be normal or could be reduced. Then we next comment on the nature of the air entry. So the breath sounds could be normal or broncho-vesicular, or normal or vesicular, or they could be bronchial if there is an underlying pneumonia, in the area that you are inspecting. In young children, however, auscultation over the trachea and the upper chest, you may hear broncho-vesicular breathing, which is normal. So there are three types of breath sounds that you will hear when you auscultate. Vesicular, which is normal, broncho-vesicular, which is normal in young children over the trachea, and bronchial breathing, which is always abnormal, and which is secondary to a possible pneumonia underlying the area that you are inspecting. In addition to the breath sounds, we may also hear added sounds. These added sounds are as important as the breath sounds themselves. One added sound is crepitations, which are held at the end of inspiration. The next one, and that is mostly heard in patients with pneumonia who are recovering, or children with heart failure, where you hear crepitation at the lung basis. There's also rhonchi or expiratory sounds which are heard at the end of expiration. They are musical sounds, and they are common in children with asthma or children with bronchiolitis. And the third one is stridor. Stridor is an inspiratory sound. You will hear it in inspiration, and it is a very ominous sign. It suggests significant obstruction to the airway, secondary to conditions such as bronchiolitis or epiglottitis or croup tracheobronchitis. These are the main findings that we hear in examining the chest in children.